everyone. My name is Sue Babin, and I am the host for It Takes a Village, which is a program initiative of the Village for Rhode Island foster and adoptive families to provide information about services and supports that are of interest to families that are kinship, foster families, and adoptive families. Today's show, we're going to talk about a very important topic on mobile crisis and treatment and support for children and families. And with us today, I have two awesome guests. I have Sarah Kelly Parker, who is the Chief of Behavioral Services for Family Services of Rhode Island, and Beth Bixby, who is the CEO for Tides Family Services. Welcome to our show.
Thank you for having us.
Yes,
awesome.
Thank you. So I want to start off with just talking a little bit about mobile stabilization and crisis.
Sure.
Those are kind of big words.
Yes.
So let's break it down first and to talk about both of your agencies and what you guys do in particular for families. So we'll start with you.
Sure.
Sarah.
Thank you, Sue, for having us. Family Service of Rhode Island is a social service and behavioral health agency that serves the entire state of Rhode Island. We do a lot of different things, serving all ages in a number of different ways. I oversee our behavioral health care services, which really encompasses counseling, psychiatry services, case management, support services, and we do that across the lifespan. We also have several child welfare programs like foster care programming, kinship support, some residential group homes, as well as early childhood services from early intervention and home visiting, and some other programs. So we really are a multifaceted agency that serves the entire state of Rhode Island.
Okay, so you're not geographic, you're the whole state,
Correct.
statewide.
Yep.
Awesome.
Yes,
Okay.
absolutely.
And Beth, can you tell us a little bit about Tides?
We're a little bit
Yes.
more targeted than Family Service. Tides Family Services is also statewide, and we work with children ages 2 to 21, and we service about 1,300 families a year. We have about 190 staff members, and everything that we do is home and community based. There's very limited services that are inside of our building, and that is based on some of the founding principles of Tides. To really make sustainable change, the founder had really thought about focusing within the family unit and the community in order for home preservation. And so similar to Family Service, we have a lot of child welfare, family preservation programs, children's behavioral health programs, and then we have several juvenile justice programs from the prevention side of juvenile justice up to some high-end reentry programs. So we also have those three buckets, and everything is from a family systems lens.
Okay, great. The topic that we're going to talk about today is really important for families, not only in Rhode Island, but Massachusetts and all across the country. Children's behavioral health is definitely in the news, right? So we're going to talk today about the mobile response and stabilization services, which is referred to as MRSS, correct?
You got it.
So explain to me in English, what is that? Like, what does that really
Sure.
mean? How do we say that so that families and people really understand that terminology?
Absolutely, and I'll start, and please jump in, Beth. So Mobile Response and Stabilization Services, MRSS, we love our acronyms in this field. It's also sometimes referred to as Children's Mobile Crisis or Mobile Response. And really what it is, it's a framework that FSRI and Tides Family Services have implemented and adopted for the last several years that responds to children and families when they are in crisis. And I think one of the most important things about this program is that the crisis is defined by the family themselves.
And that's critical. And unlike the adult system, it is really about screening in rather than screening out. And so, as Sarah said, it is a crisis defined by the family, and we go out with an immediate response. So the traditional kind of emergency response mobile crisis was, they would ask you where the risk was, and sometimes you would be sent home with an appointment a week from now. we go out immediately, and then we stay open
What does that mean immediately?
within an hour.
Yep.
We
Wow.
are out to wherever the crisis is
amazing.
happening, a school, a friend's house, if there's parental consent for that, or anywhere.
McDonald's.
Yeah, McDonald's.
So if a child is having an issue in school,
Yep.
can the schools call you, or do you have to go through the families first? How does that work?
The
school can call
yes.
Really?
with verbal consent from the parent. We can go right out.
Yes, yes.
That's
and
awesome.
and the schools are actually one of our biggest referral sources, and we both of our agencies have made really great connections with schools, and they've found that calling us. Right, if we can intervene, we can prevent an ambulance showing up at the school, police intervention showing up at the school, and really we can help kind of mitigate that crisis situation for not only the student, that child and youth, but also for the staff and the school themselves. It doesn't have to become a big, huge production with sirens,
Yes.
and so it's been we've had a lot of
And
success.
we avert the emergency room.
Yes.
That's a big
huge.
plus.
Yeah.
One of the things that's really important is trying to figure out ways that we can get information out to families. You know, we live in Rhode Island and we're right next door to Massachusetts, two kind of small states, and yet there's some services and supports that go on, and yet people don't know about them, which is why we wanted to really do this show. Why is this service so important? Beth, we'll start with you.
Oh, sure.
Yeah.
This service is so critical because, as you had said, we are in a state of crisis nationally, and there's not a lot of capacity out there for services for families. And when families are in crisis, they want immediate response. They don't want to wait a week or a day. And when they're reaching out for help, we want to respond because we don't want them to have a negative experience and not reach out again. But we are really focused on keeping kids in their natural environment with their family while we're working through that crisis and helping maintain them in whatever educational environment they have. And as you know, Rhode Island had some struggles where we had kids who were hospitalized and weren't receiving an
Yes.
education, or they were going out of state. And did they all need to be in those higher levels of care? I don't know. But I think it's really important to have kids and families stay together and work through whatever challenges are happening. So therefore, they develop those skills over time, and we can avert, further crises.
What are some examples of situations that would result in one of your agencies getting a call? Like, what are some behavioral or things that might be going on with the child that you would get the call on?
Sure, I can start. So we've had calls for things like school refusal. So if a child, for example, is having
I'm not
trouble
going.
getting to school, I'm not going, you can't make me, right? That's familiar for a lot of our families. To children and youth who are really having a hard time regulating their emotions and behaviors. So you might see aggressive behavior, you might see acting out behavior, or the other end of the spectrum, kids who are becoming really withdrawn, not engaging in their normal routines or activities. But again, I want to stress, it's the crisis is defined by the family. And I think part of this program is also trying to reduce that stigma and normalize asking for help. So what I would say to families is if you are seeing that your child or youth is struggling in any way, they are not themselves, you are their parent, their caregiver, their grandparent, whatever, and you're seeing that something is going on that's worrying you, that can be a reason to reach out to us for help.
That's really important. I know for me, my son was in early intervention, and I had to wait months. And I know lots of people. I had to wait months to even get the referral, and even with that, it was really, really difficult. So this kind of a service is so important. I love what you're saying, that you're Johnny on the spot. You're going to get there within an hour. That's really amazing
One of the other
stuff.
things I think is important, it's regardless of payer.
Yes.
That's part of the best practice model, according to SAMHSA, but regardless of insurance, it's a just go model as well.
Go.
And so we're not talking about what insurance you have. When we get the phone call, we are just going out. And I think that's really important. And the state of Rhode Island has been very good working with us because, as you know, sometimes depending on what insurance you have, depends on what service you can have access to.
Yes.
And so access is a big issue, and sometimes there's needs beyond what, 12, 15-minute sessions, and people need more support than that. And so
Yes.
they have let us also have access to a larger service array that is has different funding sources for any family. So it's for any family in the state.
2 and up, age
Yep,
2 and up?
2 and up. Yep,
Same
2
for
and
you?
up.
2 and up,
Okay.
yeah. And I think another important thing to mention is that our agencies work hand in hand together and have really implemented this model together in a way that has, we call it right in the field, fidelity. So this framework has been implemented in other states. It's been shown to be impactful and effective, and both of our agencies are implementing it the way it's supposed to be implemented, which means that
Yep.
we're getting the same
results.
Same results.
And
Yeah.
we worked closely with someone from the state of New Jersey where they had implemented this years ago, and they have 0 kids in out-of-state placements.
That's amazing.
And they have really reduced the levels of congregate care. And so really that's why it's, we're so passionate about it,
Yes.
because we really want to keep families together and work through some of those challenges.
From a family perspective, how do the families kind of see this support to them? What's their,
Yeah.
what do they say?
So, I mean, we're getting nothing but positive feedback from the families that have accessed this service. And I think one of the biggest components that families are really appreciating is, well, there's a few. One, that, as Beth mentioned, we just go, and we go when the family is asking for help in that moment. And 2, part of this model is not only the crisis evaluation in the moment of that family-defined crisis, but it's also a period of 30 days of follow-up stabilization services. So we're meeting those families in that crisis, and then we're following up and making sure they get what they need following this crisis.
And we don't just
Yeah.
focus on the child and family, we also get involved with whatever
Yes.
else is going on. So we'll go to school meetings, because if that's a driver for some of the crisis, we are very actively engaged in all parts of the family system or other systems. And one piece of feedback that I had received from a family was that they had been through all sorts of programs, and this was the first program that really was in the home and was really centered around the entire family and the entire system. They had been through multiple programs, and they said that this was the most successful, that they felt like their child had responded because of, it was immediate when the crisis happened, they didn't have to wait, and then immediately went into other services. So there was the continuum.
I was going to ask a question. You talked about the connection back with the school. So would your services, for example, if a child has an IEP, would that get written into the IEP? Because that's kind of like the Bible that's out there that people do follow, especially when a child is exhibiting some challenges or behaviors that people are concerned about.
Yeah.
But I don't know if it would be written into the IEP, but it's access for every child,
Okay.
no matter what district or
Right.
what kind of environment. We've gotten calls from private schools as well.
Okay.
Yes. And I think on the IEP, because our service is short-term, so it's usually up to 30, sometimes 45 days, it might not necessarily get written into the IEP, but our staff attend IEP meetings. They help
Okay.
advocate for families if that is what is needed and, asked for by that parent. So we might advocate to maybe have other services written in that are longer term that would help that child.
It just seems
Yeah.
that, whatever strategies you're recommending, for consistency for the
Yes.
child, it would make sense that gets carried over.
We
That's where I
do-
was going with that.
Yeah, we do have some school systems for both of us that have kind of written MRSS calling us into their school protocols around if they have students that are identifying that they're struggling or having, suicidal ideation or things like that. So there are schools out there in Rhode Island that have written that into their policies and procedures that we get called before they're calling, let's say, an ambulance or rescue if appropriate.
Okay.
And one other piece I think that is important that people don't often think about, and not to get into the juvenile justice kind of stuff, but it also helps decriminalize some issues, because as Sarah had said, an ambulance gets called And sometimes that escalates, whatever the situation is, and sometimes it could end up in an arrest or something like that. And so it really does avoid police and hospital intervention at all costs.
And that's a big decrease in terms of
Yes.
funding. Psychiatric hospitalizations, as everybody knows, is at, extremely high cost.
If you think about, we together served 1,300 children, families.
Through
in-
this
through
Yes,
this
yes.
program, and if every single
Wow.
one of them went to the ED, it would have cost $2.2 million.
Whoa.
And how many times do people go to the ED and then they just get sent home?
And wait.
And wait. They're out there for hours,
Yeah.
and if you have other children, who's going to stay with the others? And so it also doesn't put that strain on the family as well when you're sitting in an ER all night, and then you get the prescription and an appointment for a week out, So it really helps with the parents' feeling of, success. Like, I helped my child get help and not feel helpless.
Are we seeing an increase in the need for behavioral health services for children? 1,300 between just the two of you
Yes.
is
And-
a lot. So are we seeing that, and why is that happening?
Yeah, I mean, I think so, and I think, and I don't have the exact number, but that 1,300 number, I know I was surprised at the number of calls we've gotten over the course of implementing this
And you're
program.
gonna get more
that
after
are,
our show,
I know,
yeah.
that's good. That are people accessing behavioral health care for their child for the first time. I was really surprised that many of our families that are calling, they've never been engaged in counseling or therapy prior to them calling us. That was
was the
really
only way to
surprising.
get access.
Yes.
Wow.
Yeah.
How do families find out about it? What do they do? What's step one? So they
Yeah.
watch our show.
They
and
watch-
see
you
both
watch
of
our
you,
show.
ladies,
And then they just call the number.
Yeah.
Okay.
And they can also visit both of our websites,
Okay.
which we can give, and they could call 988.
Yep.
The 988 knows about us. We
Okay.
work really hard to be connected there,
Okay.
because we want families to be able to reach us in many
So
different
once
ways.
they make that call to you, you said that someone will come out to the home or wherever the location is within an hour. Then what? What exactly happens?
An assessment. They go out and do a screening and assessment. A clinician responds to wherever the call is coming from.
Okay, so talk to
Talk to
whoever's
them,
on
yep.
site at that particular.
Yep.
If it's in school, it'll be the teachers.
Whoever the caregiver is
family.
at the time, the teacher, principal, aunt, uncle.
Yep.
And do they offer like strategies for, like what are some typical things that might come up in those conversations?
Yeah, oftentimes we make a safety plan that includes concretely writing down strategies. So, for example, if it's a youth or child who is having trouble regulating their emotions and are maybe having big emotions, right? We might identify some strategies that youth can do, and the parent can help to join in with them. And we will concretely write that down and leave the plan with the family. And then we're following up to reinforce and make sure, is that working? Are you practicing it? So, teaching some really concrete skills. Following that assessment is important. And a lot of the time, Sue, I have to say, just the fact that the family has somebody that they can follow up with and call is a strategy in and of itself.
Someone who will listen and validate.
Yeah.
So the family
calms it
can,
down.
you come in, you deal with the immediate situation. Do you call the next day or
Yep.
Yes.
Or go
say,
out.
how's it going?
Yes.
You go out?
Yep.
Yeah.
We'll
Even?
we'll
We'll
also
go
yep.
out every
really?
day if we have
Yes.
to.
Yeah.
Wow.
Yep. Absolutely. And that follow-up piece, I think, is what makes all the difference. So the team responds in person, by phone, however that family would like us to respond to provide stabilization. And while we're doing that, we're working on those skills that is helping that youth and family, but we're also working to get that youth and family connected to a longer-term service if needed. Could be outpatient clinician counseling, could be a home-based service, it could be hooking the youth up with a recreation activity. It really could be a
Something
variety.
meaningful.
Yeah.
Absolutely. So we're also helping the family access those things to be
What
successful.
are the typical ages? I know you do the gamut, but is there like a cluster of?
12 to 17.
Yeah.
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 Ooh, yeah, that's.
Yes.
That's tough. That's a tough.
We've had 4 or 5.
Yes, we have.
Yeah.
Yeah, but I think the average, if you look
Yeah.
at our stats, is
Yeah, the-
12 and up,
Yep.
really. So.
And do you provide like prevention tips to the families? Do you give them any, here's a piece of paper with some stuff?
Yep.
Could
Oh,
we
yes.
find that, would we find that on your website at all so that other families might kind of take a look at some of that?
So our website does have some tips on there, but it really depends. So I think our teams, they run the gamut of issues,
Yeah.
and you never know what you're going to walk
So
into.
there's no
Yes.
cookie
So
cutter
there's no
approach.
cookie, right?
okay.
And there's, so we have a lot of different worksheets and websites we recommend, really tailored to what that family is going through in the moment.
And and a lot of things also we respond to trauma.
Yes.
Where there was a homicide that had occurred and a child had witnessed it, and we got called to go and work with that youth and family. So we also get calls like that a lot as well. Some sort of traumatic event has happened. And we also, both of us, both of our teams are very flexible when there's been some sort of traumatic event at a school. We've made ourselves available to help manage some of the issues that the school may have, either with families or help support
Yes.
teachers, whatever it is to help through that way as well.
What kind of backgrounds or training or education do your staff have to have? And do you run into problems recruiting people and maintain and retaining rather those staff in your organizations?
So the teams are made up of, we always respond in pairs. So it's usually a clinician, there's always a clinician available, so that's a master's level clinician. And then either a case manager or a peer support specialist or another paraprofessional who pairs with that. And that is the MRSS model, is responding in pairs.
But there is not a co-response model like the adult system where there's emergency personnel. It is our staff members who respond, because that can often sometimes escalate a situation. And so when we do get the call, we do screen to see, if there's any immediate safety, and if there's not, we'll right out.
Do you have a problem in recruiting staff for these functions?
I think it's not just for this program, across the board.
Okay.
There's a workforce
I see.
challenge for this
Yes.
field.
Yeah.
But for us, we've retained our team. We've had a pretty solid team, and I think the work is very rewarding, and so they really are grounded in the why, because they see the success and the success rate with the outcomes. I think that's helped retain staff.
I think it takes a special person to do this work.
Yeah.
We're lucky that we have wonderful teams that do it, because
They
you
get calls at 3 o'clock in the morning.
Yeah.
They do, and you do see an immediate impact, I think, because we do respond right away, and we're helping families when they need it most.
Right. What about situations like abuse or something that may happen to somebody in the community and that's contributing to the trauma that the person already has experienced? Would you come in on those kinds of situations as well?
If someone was abused, of course, yeah. And so one thing that we're starting with DCYF, I think that the village folks would really love to know more about. We're just starting to get it off the ground, but it's modeled after a pilot in New Jersey for youth going into foster care, or children going into foster care, because sometimes it's a traumatic event that just happens, and it wouldn't necessarily be a behavioral health kind of response, but it would be a supportive response for either the foster parent or the child, or for both, to say it is normal to feel this way. What just happened to you, is something that is overwhelming, and really try to validate the feelings and to see how we can help support the foster parent and the child, because that is something that I think it's not that it's overlooked, but we want to prevent disruptions. And in New Jersey, I think they had a 94% success rate keeping kids in their first placement. And so we're hoping that we can model that, because that is I just think of over the years with all the kids and families I've worked with that have been involved in the child welfare system, there's so many disruptions, and you need to establish roots, and that's why I love, it takes a village, because that is so important. The village, having roots is critical, and so Tides and Family Services are going to be doing that in partnership with DCYF.
And that's why the village really started, to provide peer supports to families, and that's been really, really effective. One of the advantages that we have being in Rhode Island, advantage and disadvantage, you can get the word out pretty quick when you use a lot of different ways to get that message out there. But this, topic that we're talking about is really important for families. Sometimes they don't know where to turn. Sometimes the families are hesitant to make a phone call because they think it's reflective on something that they may or may not be doing. And so they're hesitant to even make that phone call, for fear that something may happen on the outside.
I think it's a positive thing that we go right to the home, because if you have to go somewhere, it can be very anxiety provoking, and you think everybody is judging you, or like, are they wondering what kind of parent I am because my kid's got challenges? We go right to the home. It's very private. And, we're inside at their kitchen table, doing the assessment. So it's a very natural environment.
So, go ahead.
Oh, I was going to say, and we know that it's hard for families to ask for help. So that's why, we just go. So if a family is calling us and asking us for help, we know that's a huge step, and we don't want any barriers to that. So we will come.
We just go.
What's been the impact in the state? Have you been able to collect data and scenarios and individual stories to because this is an area that I'd love to see some an increase in funding. Right? But
or sustainable funding.
Yeah, sustainable funding.
Yes.
So we've gone. I mean, the percentage goes a little up and down. I don't know if
it goes between 90% and 92% success rate
of diverting from either hospitalization,
you
law
gave that
enforcement.
Figure, $2 million. That's pretty significant. But these are the kinds of things that we need to educate the public about and educate our legislators about, right? So that they understand.
We do have a bill in right now for that.
Okay, perfect. Love that. Let's see. Last question. How are these services are you the only two agencies in Rhode Island that are funded for this service, or are there other organizations funded by DCYF? I assume DCYF.
For DCYF, we're the only two for that pilot project for foster families.
Foster kinship?
Foster kinship, yep.
Adoptive families or no?
It could be. It's we're starting small with the pilot to see how it goes.
Okay.
But the larger program that is open to everybody in Rhode Island, all youth, children and youth, is funded through the Certified Community Behavioral Health Clinic initiative, which I won't bore you with those details, but and Family Service of Rhode Island and Tides are the two of the providers, and then there is one other provider, Newport County Mental Health.
Okay. Well, believe it or not, this is the end of our show. This is such an important topic. I really appreciate both of you coming and talking to us today. We're going to get the word out to families and put your websites up there so families can also access additional information. So thank you very much.
Thank you
so much for having us. And you can see Sarah and I are very passionate about this program.
Absolutely. Love it.
Thank you.